Hi, everybody. Welcome to today's Tuesday topic. And today we're going to talk about DIC. What's it all about? Next week, we'll have DIC part 2, and I'm going to spend the majority of time in DIC part 2 talking about the utilization of TEG. Hopefully, everybody's had some exposure to TEG and are utilizing the TEG monitor to actually look at platelet function and coagulation fibrinolysis. And so to begin, I always have to start whenever we're going to have any discussion whatsoever about clotting and fibrinolysis. We always have to remind ourselves about the coagulation cascade. Now, a lot of things are important to know about the coagulation cascade. It really is important when we're talking about critically ill patients. We're talking about bleeding. We're talking about MTP and other methods of managing our patients' blood flow and blood carrying capacities. But what we really always just want to appreciate is that you have certain factors, those factors that actually go in a cascade to making a clot. And when you make a clot, fibrinolysis begins. And it can be very remember that you have many clotting factors. Here, they're all seen in red. You have many clotting factors that must actually be activated. Now you're seeing the activated factors here in green. And so what's really important to remind yourself when you're looking at laboratory tests or you're listening to somebody talk about clotting and fibrinolysis, it's only the activated factors that are working, that are really important, because once they're activated, they stimulate the clotting cascade. You have the intrinsic and the extrinsic cascade. One is exposure to protein, the other is tissue injury. It doesn't really matter. The only reason we even separate, we as bedside nurses separate these cascades, is because we look at what we're going to utilize to support or block the clotting cascade. And that's the only reason we care about the difference between intrinsic and extrinsic cascade. So remember, red are all your factors. They actually have an enzymatic change to become activated factors, and activated factors are green. All the activated factors come to a common purpose. That common purpose is 10A. 10A is actually excited or exacerbated by both intrinsic and an extrinsic pathway. And once you get to 10A, you have what we call the common clotting cascade. And this is really where much of the work that we do, where we're supporting clotting, where we're blocking clotting, really begins, most of it begins in earnest right here. Now, we can do a lot of things at these other levels, but really in earnest, we're looking here. Activated clotting, and then anticoagulation, looking at the activation, which stimulates, really, really important, the utilization of ionized calcium, the stimulation and activation of thrombin into factor 5A, and prothrombin plus factor 5A yielding thrombin. Now, all I really care to say here is that at the end of this activation, you release fibrinogen, which then actually makes a sticky spider web at your injury or in the vessel surface, and that spider web actually collects platelets. So two things that are really, really important in clotting, both the cascades and in terms of stimulation, but ultimately, three things really: ionized calcium, the fibrin weave, and platelets that have been activated. That activation of platelets actually promotes the mobilization of platelets and actually the stickiness of the platelets so that they can adhere to the fibrin weave in order to make a functional clot. Now, that was very simplified, very quick overview of the clotting cascade. But it's really important for us to appreciate, because when we talk about DIC, DIC is not a primary diagnosis. DIC is a symptomatic or secondary response. That's really important. So we're not looking for DIC to be a diagnosis. We are looking for it to be an end product of something that's been out of control. Obstetrical complications, trauma, MTP, surgery, sepsis, something that activates through, and most likely through inflammatory mediators, activates the clotting cascade. So what is really, really important when we say DIC, disseminated everywhere, intravascular in the vessel, coagulation, disseminated intravascular coagulation. Now, normally you actually control your clotting at the area of injury, and that's typically controlled there through combination of factor activation through your blood flow. And it's usually a very controlled process. I make a clot, I stop bleeding, I ultimately lyse the clot, bing, bang, boom, done. But when we talk about overstimulation of the clotting cascade, such as sepsis or trauma or MTP, and other reasons as well, obstetrical emergencies, there's lots of reasons. But when the clotting cascade is overstimulated, then you start making clots everywhere. And when you're making those clots, they're not actually because they're responding to a particular injury. They are just clots, clots, clots everywhere. And that typically is in the microcirculation. So the very first thing to remember about DIC is that you are activating coagulation, okay? Now, because you're activating coagulation, that's primarily in the vessels, you're going to actually consume your clotting factors because you're making so many clots. And there's a reserve of clotting factors, but now you've consumed them all. So now you've consumed all those clotting factors. What we're actually reminding ourselves is that our patient has millions, billions of microclots, but they can't make a bigger clot. So if I actually stick an IV in them, a central line, a vas cath, or God forbid, they go to the OR, they're not going to bleed to death. They could bleed to death because we've consumed all our clotting factors. We also tend to have consumed all our platelets. Now remember, the endpoint of the coagulation cascade, either side, that endpoint is to actually release pro-clotting and anti-clotting at the vascular surface, and to also stimulate that sticky spider web known as fibrin. And our platelets, which are activated, mobilize and roll along the wall till they get to that fibrin weave, making a clot. Now that's happening everywhere. That's happening everywhere. So when I'm evaluating the patient, I see that yesterday his platelets were 270,000 and today they're 75,000. Where did all those platelets go? He didn't lose the platelets because I did some blood draws. He is actually most likely consuming the platelets. That's the consumptive coagulopathy that we talk about with DIC. So he's consuming platelets at that fibrin weave. He's consuming his coagulation factors, but it's really important to remember that at the same time that you're making a clot, you are actually also stimulating clot lysis or fibrinolysis. So what we typically will see by laboratory analysis, platelets have dropped, PT and APTT are prolonged, so clotting times are prolonged, and we see the byproducts of fibrin degradation. FDP, FSP, D-dimers, really all the same measurement, looking at the lytic products of all those clots. But I may have made 3 million clots, and I've only lysed 1 million. But the problem, of course, is that when I lyse a clot and I have clot byproducts circulating in the blood, that actually is going to inhibit any further clotting. So this is when the patient gets into problems where you might see them bleeding profusely and possibly bleeding to death because they have, again, a vas cath, a central line, a PA catheter, an IV, or they have surgery or the smallest amount of disruption to their skin integrity or any vascular surface. they could bleed to death. Now, the other side of this coin, and it's one that's really, really important. DIC is a consumption of our clotting products. So it's procoagulation. It's also a high-level release of fibrinolytic. So it's also anticoagulation or fibrinolytic. And in addition to that, as this is all rolling along the vascular wall, you're going to start to see some endothelial damage. So one thing that people don't think about, especially with something like sepsis, is this is an endothelial disorder. So our endothelium works in balance, pro and anti vascular constriction. So pro-constriction, anti-constriction, or dilation, pro-coagulation, anticoagulation, pro-fibrinolysis, anti-fibrinolysis, and your vascular surface of your endothelium is an incredibly rich and abundant surface, making all these products in balance to respond to what the needs are in those moments and seconds. But when you have aggressive endothelial damage, you're going to have a high-level formation of microvascular thrombus, right? You consumed your platelets, you consume your clotting factors, and you have all these micro thrombi, micro occlusions in small vessels. Your patient can't make a big clot, but they've made billions of small clots, and that actually occludes blood flow. So the end result when we have DIC is you have a possibility to bleed to death, but you also have occlusion to perfusion. Because of that microclotting, you don't actually deliver adequate blood flow and tissue oxygenation. So when these mechanisms are out of control, this is what leads to that syndrome that we call DIC, disseminated intravascular coagulation, also referred to as consumptive coagulopathy. And we have two groups really that we look at. First is the acute patient. So we see that patient most particularly when we have severe, or what we used to call severe sepsis, but now we would call septic shock. So when we see patients in septic shock, when we have patients who have an amniotic fluid embolism, again, remember obstetric emergencies, severe trauma and bleeding, and of course, MTP. This is a big problem with MTP is your patient goes on to actually elicit acute DIC. So really important, I've got another slide that says in acute DIC, when you're first evaluating that patient, the problem is bleeding, 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 and more bleeding. Chronic DIC is sort of more related to a chronic hyperstimulation of inflammation, therefore the coagulation cascade. So you see that more with chronic neoplastic disease, with chronic inflammatory response disorders that then have a secondary stimulation. So really, chronic is something we should always suspect, depending on where we're working, in patients who have chronic hyperinflammation or chronic neoplastic disorder. We should always be thinking about chronic DIC. Happens much more slowly, and their problem, their tendency is not to bleed aggressively. Their tendency is to clot aggressively. So in acute DIC, you do have microcoagulation, but the more prominent feature is bleeding, 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 and bleeding. And a chronic DIC, you also have bleeding complications, but the more constant complication that you see is clotting, 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 and clotting. So we have to be familiar with how this is evaluated in order to understand it, in order to be sure that we're prepared for what is going to occur for our patients and how we're going to treat them. So again, we look at acute DIC, it's typically bleeding, bleeding, bleeding. It's in the subcutaneous tissue, it's on the skin, it's in the mucous membranes. And remember, they also have procoagulation that occludes blood flow in the microcirculation. So one of the things that happens, this is all, it's all very interrelated and quite complicated, is we have a lot of alteration in our vascular tone. So frequently these patients will have acute vasodilation, such as you see with severe sepsis or septic shock, that they have really acute vasodilation. They have a lot of inflammatory injuries along the endothelial wall. They are procoagulant, consuming their clotting products, including perfusion. So despite what you're doing, you're not really improving blood flow because you can't get past these microclots. So that is a really critical perspective. And this is, I love that definition, explosive generation of thrombin, which rapidly depletes the clotting factors, rapidly depletes the platelets, and prolongs your bleeding time, because now when I have a larger wound, IV, a central line, a vas cath, a surgery, I don't have enough clotting factors available to make a clot. And a lot of times we can't actually improve this very much by giving patients clotting factors, because it's just going to get consumed in this catch-22 of DIC. So we're going to consume all those clotting factors down at the microcirculation. Unfortunately, that's really all we have. And so we tend to do it, but it may actually make the situation worse. Now, remember, chronic DIC is basically the same process. Procoagulation, cascade, both intrinsic and extrinsic, down to the common coagulation pathway, making, consuming your platelet, consuming your clotting factor, stimulating fibrinolysis, and therefore products of fibrinolysis in the blood go up, 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 up. Now, much more significantly hypercoagulable. So that's a really important concept. So just a simple cartoon, hyperinflammation. So just remember, hyperinflammation, trauma, acute injury, acute MI, severe acute MI and cardiogenic shock, obstetrical emergency, sepsis, all are hyperstimulating. And that hyperstimulation from inflammatory mediators that are circulating will stimulate clotting. And that will intravascular thrombosis, causing hypoperfusion to your overall tissues and your organs. And that's going to lead to ischemic damage, damage of the kidney, damage of the mesenteric bed, the liver, the spleen, the heart, the brain, damage everywhere, because I've occluded perfusion. So I don't want you to forget the number one issue with DIC, and DIC, remember, is a symptom, not a diagnosis. But the number one issue with the symptom DIC is occlusion to perfusion because of that intravascular thrombus that's been formed. Secondly, bleeding. You've consumed your clot, a stable clot, because you now can bleed more, you can more. You're consuming your clotting products, and actually, with that consumption of clotting products comes an extra stimulation of fibrinolysis, which will further affect your ability to make a stable clot. Oh my gosh, it's such an amazing circus of pro and anticoagulation and pro and anti-fibrinolysis. Now, remember, whenever coagulation has been stimulated, the second thing that's going to happen is a stimulation of fibrinolysis or thrombolysis. So now my patient is going to release anticoagulants, and of course that's going to make them bleed again. So bleed, bleed, clot. Bleed, bleed, clot. And that clot limits your perfusion, promoting infarction of all of your organs. So a lot of times we have patients with DIC, we're seeing fulminant purpura, you know, the bruising that occurs all along their skin. And we also start to see mesenteric ischemia and kidney ischemia and adrenal ischemia. And now they've got ARDS, and we're just like, what went wrong here? Well, what went wrong is that their own body in hyperstimulation actually promoted this profound abnormal activation of their cascade. Okay, so first and foremost is patient history, of course, as it always is. And it always, remember, the symptoms are those typically of the underlying cause. You've got renal failure, you have pulmonary dysfunction, you're already bleeding, you have a GI bleed, you have petechiae, ecchymosis, you've gotten a lot of lines, you've gotten catheters, you have surgical sites, drains, trachs, all sorts of stuff. And actually, one of the things we look at a lot is the presence of jaundice. These are all really important clues to the diagnosis of the secondary issue known as DIC. Bleeding is the most common and prevalent clue. So here you're seeing purpura fulminans, right? 84 to 95% bleeding can occur anywhere at any time. Just from a simple touch, you now have bleeding and bruising and oozing. Now, bleeding is the major clue that we see in acute DIC. So as we're talking about a patient who's oozing around their IV site or oozing around their central line, oozing around their surgical site, oozing around their Foley catheter, and you're remarking that they're oozing, you should always be concerned that this may be an early clue to the diagnosis of DIC. Now, what else you're going to see is, of course, thrombosis, hypotension, shock, and organ dysfunction. So thrombosis, remember, in acute DIC is that second event. It may actually occur close to the same time, but you're not going to see significant signs and symptoms of thrombosis like you see bleeding. I did a blood draw, you're bleeding. I might not see thrombosis until I start to see digital ischemia. And many of you who've been around for a while will remember that early in sepsis, before we really tried to improve perfusion as an early indicator or as an early methodology for treatment, we would often see patients that had pretty significant digital and profound ischemia or thrombosis. Now, a lot of times you might say, when you look at this foot, you say, oh, that patient's got DKA. Well, he might, but that's not what we're looking at here. This is an acute occlusion, and that microocclusive disorder, most particularly in terms of what we can see, happens in the digital extremities. Now, think about what's occurring here is that I have very significant profound hyperinflammation, very significant profound procoagulation, a significant component of fibrinolysis, and I have endothelial damage, which is now promoting vasodilation. So what I'm going to do as the bedside nurse is I'm going to give you fluid, and then I'm going to give you vasopressors. I'm trying to get your MAP up. The problem is that may make this all significantly worse. So it is just something you have to be aware of. As you know, I feel that we should always have an endpoint for titration of vasopressors. And when what that endpoint is, and you should have that discussion with your provider and not accept just titrate until their mean pressure comes up. That's just not good enough. I need to really have a target for what I'm trying to achieve with the titration of my vasopressor, because what I don't want to do is worsen ischemia, which can, of course, happen and does often happen with patients who have profound hyperinflammatory syndromes. Next to that, of course, we're going to remind ourselves that once we have this fibrin deposition and platelet aggregation in the microcirculation, you're going to have ischemia and you're going to start to see failure of multiple organs. So here's the thing. It's really important not to try to separate this in sepsis. Sepsis is a profound hyperinflammatory, inflammatory state out of control, promoting profound coagulation and fibrinolysis, and ends up actually terminally with profound multi-organ dysfunction that occurred because of that pro-inflammatory, pro-coagulation, pro-platelet activation response. Now, those of us who've been around, some of the people on the call I know, so I know they've been around, that would be Ms. Hazeltine and that would be Miss Cecilia, who've been around a long time. We will also remember that about 20 years ago, there was a drug called Zygris. It was human recombinant activated protein C. And what it did was it promoted fibrinolysis. And so those microclots were being destroyed by that human recombinant activated protein C, also known as drug-tricotrin alpha activated. Took me a long time to learn how to say that But really, most of us will just think about activated protein C, or Xigris. That's what we think about. It was on the market for about 4 years. Everybody thought it was a miracle drug. They gave it to everybody, even patients who did not meet specific criteria. So it was pulled off the market because, of course, patients bled to death after you administered Xigris because it was being administered inappropriately, too late, and for patients who didn't really meet criteria. But the idea of it was to actually destroy those fibrin deposits so that you could actually maintain and sustain blood flow. For those of us who really liked it, a lot of people, especially hemodynamicists, really felt that this was a significant step forward in the treatment of sepsis, but it just became something that everybody was using. It was really expensive and it wasn't being used. I'm not saying I knew how to do it properly. I'm just saying in retrospect, we realized it wasn't being used properly, not that I knew how to do it. Okay, so for us as bedside nurses, we need to recognize early on that our patients are having an uncontrolled thrombin generation. What that means is you're paying attention to the drop in your patient's platelet. The most simple is to look at the drop in your patient's platelets, and the next most simple is to look at the prolongation in clotting time. That should always spark a concern. And then we communicate with our team of our concern that the patient is consuming his platelets and prolonging his clotting time. And that next step will be, I hope, will be a much further in-depth evaluation. But really important that we're recognizing this early, because this is the time that you really want to do what you can to control the inciting event. You're in your last trimester, you're in the hospital, you have preeclampsia, we're going to deliver your baby because your baby is the nidus of your inflammation. You've got sepsis, we're going to do broad spectrum antibiotics, specific antibiotics, and if necessary, we're going to take off your toes, we'll take off your foot, we'll take off your fingers, we'll remove whatever's the nidus of your inflammation. But a lot of times, we're not correlating that data well at the bedside. It's our role as bedside nurses to gather that data so that we can present that to our colleagues and say, our patient looks like he is consuming his clotting products. Do you think this is a sign of DIC and hyperinflammation run amok? And what we can do over here, and that's what we do, is we support the failure of your organs, right? We intubate you, we put you on a ventilator, we put you on CRT. Some places are doing liver support or other kinds of support. Really important. Early recognition and significant support. And you might do that support proactively. I also want you to remember that part of this process is inflammatory injury. And once you have inflammatory injury, you're going to lose some vascular tone. So as you lose vascular tone, another good sign, it's a little bit later, but it's a good sign, is refractory hypotension. So, oh my gosh, I come on today and my patient's on 30 of norepinephrine and 10 of epinephrine. The first thing I'm going to do, because for me, it's not sitting at my desk charting an epic. The first thing I want to do is I want to gather my information so I can participate in rounds. And so I can say, hey, this patient has refractory hypotension. I have titrated from 4 of norepinephrine to 30 to maintain his blood pressure. And along with that, the patient is consuming platelets and he has a prolonged clotting time. Do we think that he now has a secondary diagnosis of DIC? And what are we going to do about that as we evaluate our patient and as we are considering what's next in our episodic journey with this patient whose life we're trying to save? Okay, so really just important to remember that this patient is going to go on to evolve multi-organ signs, right? Because I want to make sure you remember he has occlusion to perfusion. Millions, billions of microclots consuming all those clotting components and occluding perfusion. So really important, and unfortunately completely sensitive and absolutely not specific. So just making sure that I don't mean to make anybody feel bad, but just remember, when you're looking at signs and symptoms, you have to say, is there something that is particular to this? And there is something that is relatively particular, but it ain't the cardiovascular signs, because hypotension, tachycardia, and circulatory collapse, that pretty much describes all of our patients in shock, whether it's hypovolemic, hemorrhagic, cardiogenic, vascular tonal shock from sepsis, or post-anesthesia shock. That describes most of our patients, but it is something that you need to be really aware of. And I'm going to tell you, tachycardia is anything that's sustained above 100. Now, it doesn't necessarily mean that's a bad thing, but we should be noting that, charting it, talking about it, letting our colleagues know. Now, the other thing you're going to see is some change in level of consciousness. Well, okay, that's a blood flow event. That's also a hyperglycemic event. It could be an electrolyte event. It could be a stroke, be a TIA. So again, really sensitive, but not specific. Okay. Some things that are going to be a little bit more specific are going to be bleeding into serous cavities, signs of subacute bleeding. So remember, what we're looking at is your hemoglobin is dropping, your crit is dropping, you have a prolongation, your APTT, you have a prolongation, your PT or INR, and you are utilizing your clotting products. So platelets are going down, thrombin is going down, if you're looking at that, but most of us are certainly looking at platelets. We should be paying attention. Now, also, your patient is going to develop some signs of ARDS. That's in relationship to DIC. Again, relatively sensitive, but not very specific. Same thing when we talk about GU signs. Patient, except for one, and that is if you are seeing hematuria. Not hemolysis, but just hematuria. So the urine has changed in terms of integrity. Obviously, urine output's gone down, but the color of the urine has also changed, and it looks more tan or a little bit rustier. I need to send a UA off for evaluation for hematuria. And of course, you can go on to evolve some renal dysfunction, again, of course, because of occlusion to perfusion. Now, if this happens under my care and during my shift, this is going to be much more specific. If my patient has petechiae, he's developing purpura, he has hemorrhagic bulli, so he's got like little blood blisters. He has peripheral cyanosis, that's known as the acral cyanosis. If there's some skin necrosis, purpura fulminans of the lower limbs. If I feel like every time I touch him, and every single little stick I make, he is bleeding. That is a much more specific sign for DIC. So let's remember, acute DIC, bleeding everywhere, multiple sites, ecchymosis, mucous membranes, visceral hemorrhage, and ischemic tissue. Whereas chronic DIC, which I don't think we're as suspicious of, but we see that in patients who have that chronic pro-inflammation. And again, it's really most common for us, for those of us who are not working in OB, is that we're seeing these patients who are cancer patients, much more common to see it there. But they have signs and evidence that they have a DVT, they have arterial thrombosis, they may have some superficial venous thrombosis that doesn't typically end up as a DVT, and they may have many thrombus in multiple areas, and they have serial thrombotic episodes. What that means is they came in, they had a DVT, we thought we made them a little bit better, we sent them home, now they come back with 3 more DVTs and a PE, that it's in series, that it continues on because this is a chronic problem. So remember, first and foremost, DIC is not a primary diagnosis, it's a secondary diagnosis. Here are the most common primary diagnoses for DIC. So we always want to be aware of that in these types of patients that we're seeing. This others encapsulates most particularly patients who have a pro-inflammatory response like sepsis or other autoimmune disorders with a pro-inflammatory response. Now, don't get nervous because there's lots of things going on here, but this is such a great visual that shows you at the end of this, your patient probably not going to survive, right? So what we're looking at here is infections, sepsis, other things that promote a broad inflammatory response. Okay, so when I'm thinking about my broad inflammatory response, I'm going to think about my white count, and I'm going to think about bandemia. So looking at my CBC, looking at the diff, focused on the overall neutrophil count and the overall count of bands, which are baby neutrophils. So when bands goes up, it means that you're spilling immature neutrophils into the circulation because you're consuming your inflammatory products. So infections and sepsis for most of us, trauma, APL, we're talking about cancer patients, we think about MTP, all of those things which are pro-inflammatory. Pro-inflammatory stimulation also causes injury to the endothelium. That's called the glycocalyx. That's why your patient gets all swollen because they've lost their barriers, right? And we look at that relationship. So clotting increases, but that's in the microcirculation. Anticoagulation increases in order to dissolve thrombin. Fibrinolysis increases, anticoagulation decreases, so sorry. Fibrinolysis decreases because you've consumed these products, because you're making so many clots, you've consumed the anticoagulation mechanisms, or they are actually muted at the endothelium. Remember, I talked about already human recombinant activated protein C, that was Zygris. We also did a clinical trial for about a year using TIFP, using these anticoagulant mechanisms and supporting them, but you could support one, but all the others would be in constant state of flux. So we never really had very good results. Okay, so microvascular thrombosis and organ dysfunction, consumption of your clotting products, which then leads to bleeding. Okay, and this is really called the thrombotic phenotype. Now we're going to see thrombosis in all patients with DIC. Remember, it's going to be more prothrombotic in kind of the early stage of hyperinflammation and in the more chronic patient. So we always want to treat the cause. This is the response, right? We want to try to treat that cause. We want to manage whatever is stimulating that clotting cascade. Then we move down here to systemic fibrinolysis or fibrinogen lysis. Call it fibrinolysis. So very important that we understand, like TPA and Nexin 2, this is all released from the intact endothelium. So as the endothelium is hyperstimulated, you're going to have a higher degree of systemic fibrinolysis. It's hyperstimulated. It was hyperstimulated partially because of clotting. And what you're going to see is a rise in the byproducts of clot lysis. So that'll be D-dimer, FDP, fibrin degradation products, or fibrin split products. That's what we'll see when we look at a coagulation panel. And again, no one's expecting anyone to be a hematologist, least of all me. I am not a hematologist, and there is so much to know. But what we do want to be sure is that we are looking at our patients saying, he's bleeding and he's got evolving organ dysfunction. Oh, and when I looked at his coagulation labs, I see D-dimer is up, FDP is up, fibrin split is up, depending on what you're measuring. And I see that clotting times are prolonged. I'm carrying that in a package. Organ dysfunction, refractory hypotension, increased D-dimers, decreasing platelets, prolonged clotting time. There's just really one thing I can say, and that is that I have now activated DIC. Okay, so these are all the names that a hematologist would throw at us, but what we just want to remind ourselves: procoagulation, platelet consumption, pro-inflammation, the complement cascade, which is what is the inflammatory stimulant, and pro-fibrinolysis and consumption of fibrinolytic products and destruction of the endothelium. This is what brings us to DIC. Now, we don't all have to be experts in hematology to actually say, I am looking at a patient who every time I stick a needle in him, he bleeds profusely. I put in a Foley, he bled profusely. I gave him an OG tube. He bled profusely. There's blood in my suction catheter. He's bleeding profusely. You don't have to be a hematologist. But now you're going to correlate that to signs of organ dysfunction, refractory hypotension, and to your basic clotting cascade evaluation. So you're looking at clotting times, you're looking at platelet consumption, you're looking at fibrin, you're looking at fibrin degradation. And if you don't have one, my friends, you need one. You need to ask for one. Everyone is going to give you permission to do a coagulation profile. There's no reason not to, but if people aren't with you at the bedside, they might not be seeing what you're seeing. And you have this incredible responsibility to actually report on what you see. So again, I don't want you to get worried about what I'm showing you here. Don't get worried about it, because there's lots of different names of all different pathways. Here's what I want you to remember. The leaky patient, he has endothelial permeability changes, loss of his glycocalyx, which is part and parcel of hyperinflammation and DIC. His white count and his bands are going to go up. His monocytes, his neutrophils, the baby neutrophils, those are all going to elevate until they've been consumed, and then they're going to plummet to well below normal. You've got to pay attention. And he has decreased platelets. So all of this, I love this visual, but what I really want you to see, leaky, white count in bands and neutrophils, elevated, platelets are down. I'm going to actually communicate and effectively and assertively, not aggressively. I'm going to be respectful that I'm not a hematologist, that I may not understand everything about the clotting cascade and the inflammatory cascade. But what I can do is say, my patient meets these 3 basic criteria. And in addition to that, they may have prolonged clotting time. Okay, so one more time, just want you to see that at the end, what's going to happen is that you're going to make that sticky fibrin clot. Your platelets are going to be activated. They're going to adhere. Your red cells are going to adhere. And these are all down in the microvessels. So the really important thing for us to remember, because I think sometimes people have some issues with understanding that this is both a procoagulant and a profibrinolytic disorder, all at the same time, making clots, dissolving them, making clots, dissolving them. That's why our patient bleeds. And that's also why he has all those microclots. That's really the extraordinary underpinning of DIC. Now, this is from a beautiful video. You can see it right here. Really nice. It's a nursing video. I just took the picture of the very front page because I thought it was really beautiful. I didn't watch the video, so I can't validate that I would agree with what the video is saying. Not that that's important in any way, but I would definitely disagree with this. Is for us, we see I mean, it's not common, but it's frequent that we see DIC. And these 3 big descriptions here: accelerated clotting within the blood vessels and in the microcirculation, uncontrollable bleeding, and an increased consumption of platelets and clotting factors. Really simple to explain, really simple to try to understand, really difficult to do anything about. That's, of course, the real problem. So just want to remind you, there are some basic treatment strategies. They are not the best treatment strategies. They don't significantly change the outcomes for patients, okay? But if you actually see that you have a patient who is consuming their platelets, but they're not bleeding and they have no evidence of multi-organ dysfunction or ischemia, you're not going to treat them for now, but you are going to heighten your observation. You're going to ask for a heightened observation. You're going to heighten your observation of the patient. But if they start to bleed, we're going to give blood components. Now, we're really going to make decisions, quite honestly. We're going to make decisions based on what we know, but we're also going to make decisions, I think, really important to make decisions based on your TEG profile. And that is incredibly and profoundly important. But if you're just starting, you don't have TAG, you're just looking at basic, and that's okay, looking at basic blood values and basic laboratory analysis, going to give blood components as they're needed. You give FFP, you're going to give cryo, you're going to give platelets, you're going to give factors. Those are things that we're going to do. And with ischemia, so if you've got both bleeding and thrombosis, once you correct their bleeding risk, not before, you might actually administer anticoagulation. Now, 50% of people think that you should do some type of anticoagulation therapy. The other 50% don't think that you should. There isn't actually a significant and profound, strong body of evidence that anticoagulation, somebody with DIC, is going to be beneficial. But a lot of times we just don't have anything else. So remember, we're not going to ever talk about anticoagulation, somebody with acute DIC, unless we have evidence of microthrombus and unless there's evidence of organ ischemia. So with organ ischemia, we're going to consider anticoagulation. With chronic DIC, as long as they don't have thromboembolism, we're not going to give any therapy. But sometimes with chronic DIC patients, they're going to just be initiated on prophylaxis, most particularly with low molecular weight heparin. And that's just in order to be prophylactic to assist with them with the risk of thrombosis. So I'm going to end here. Just saying that we really need to find some good ideal testing. And I want to make sure that we all appreciate that we're going to do the best we can with what we have and with what our colleagues and ourselves understand. That testing should be simple. It should be objective and not require a subjective interpretation. Should have very real values. Should be discrete, reproducible, diagnostically specific. And no standard routine coagulation monitor meets these expectations. But the closest thing to meet this would be TAG and ROTEM. So when we come back together next week, hopefully you'll come back next week, I'm going to talk about monitoring coagulation, anticoagulation, fibrinolysis, some of our standard testing, and I'm going to talk about the utilization of TAG in the evaluation of what it is that your patient needs. I have about 8 case studies using TAG, and most particularly using TAG with trauma, but I have some patients that have heat stroke and sepsis. So we'll look at utilizing TAG with those patients to really define what it is your patient needs to actually head off profound bleeding and clotting disorders. Hopefully over time we'll discover that that actually also helped us with DIC. Now there was a request for me to go back. I have a lot of different pictures of the coagulation cascade, but that request looking at the intrinsic and extrinsic pathway, which is really all about exposure of protein, blood, and tissue. And it's really, really important to remember that the common pathway, when we get here, is that common pathway, that we're always going to think about the common pathway as the most important issue when we're considering clotting and clotting cascades and pro-inflammation. So with that, I'm going to end for today. I'm going to try to be respectful of your time. It's 8 minutes before 5. I'm so very grateful that you joined. I hope you'll come back next Tuesday so we can have a further discussion of TAG. But I want to make just a little disclaimer, just a little bit. I am going to teach critical care in a country that may not have excellent internet access. So I will actually post on, if I'm able, but if you come to Tuesday Topics and I'm not there, just know it's because the place that I am, that I'm residing, that I'm teaching critical care for 2 weeks, that I may not have sustainable internet access and that my internet might be very variable even if I find it. But if we have any problem with that, we will, of course, do it later. And if I have time before I go, I might even record the session if I'm able to do it. And I just want to let you know, I want you to just be thinking of me, praying for me, hoping for me that everything goes well. And hopefully we'll be together next Tuesday. It'll be 11 or 12 o'clock my time, 4 o'clock your time. And I'm very happy that you joined today. And now I'm going to stop my recording